A lot of people are struggling now with ongoing symptoms. We're hearing a lot of terms like, am I breaking down and no one told me what's going on? Or doctors say I'm fine, but I feel terrible. Who is watching what's happening with our health? Is anybody really interested? These are the kinds of things that are going through patients' minds. The sad part is that the medical fraternity also has these questions. Why are people getting sicker? Why are they presenting in unusual ways? And I am coming from a very unique angle in that I really know what happens with regards to what goes on in hospitals. I have been doing 6 years of COVID research, and critically, I've been taking apart the epidemiology with regards to hospital episode statistics. This is 186 million data points, and I'm trying to analyze them. And so I'm bringing some insights to you now that are probably a few years ahead of consensus medicine because not many people are interested. This is I am that person who in the 1960s, when I saw everybody smoking, I would have been saying they're going to get sick. And I would be looking for the health complications. At that time, there was a lot of push by the smoking lobby, and they were saying that the risks were being overblown. People were fine. People were actually doing well on smoking and so on. And so it was being pushed under the carpet until it became so blatantly obvious that it couldn't be denied. I think we're in a very similar situation where at this point, there are so many unusual patterns that absolutely correlate with what I've been saying for years that I don't think this can get away without being some kind of disaster. And I'm just going ahead of the science and trying to see if I can find ways to help you to understand, because at the moment I have to wait on the scientific and medical community to actually be this interested in the data. So, what I've done now is I've done an analysis on surgical complications. So, I've been going through layer by layer. I've done cardiovascular, I've done neurological, I've done kidney, I've done liver, I've done eye, I've done immune privilege, and I just keep on going one after the other. And at the end of these, I'm going to end up with probably tens of dashboards breaking down all of the patterns that are occurring that can't be ignored. Because what I've done is I've looked from 2016 to 2025, looking at anything that has changed that could be relevant. And the one I'm looking at specifically now is T82.4, dialysis catheter complications. And these are ICD codes, International Classification of Disease. And essentially, every time you're admitted to hospital, you're given a diagnosis, and that diagnosis is then coded. And it's a very important statistical tool to try and understand, well, what exactly is happening in the population and what can we predict from it. Don't ask me why post pandemic it seems as though there's little interest in this kind of analysis. It looks as though there's a scientific inertia. My suspicion is that everybody's afraid of finding something they can't talk about. There are elephants everywhere. But from a scientific point of view, we can't be afraid of that. We still need to look at the data. It's happening slowly, but I think it's happening too slowly on behalf of the patients. Here is the ICD breakdown. I said ICD, International Classification of Disease 10. When we look at T82, and this is the one I'm looking on with regards to surgical complications, it's looking at complications of devices, implants, and grafts. So it then is broken down within T82. You have T82.0, then T82.1, 0.2, 0.3, 0.4, 0.7. And each one is related to very specific complications that occur with regards to implantation of grafts. And so if it's mechanical complication, like say for instance, it broke or kinked, this would be T82.1. The one that I'm specifically looking at is this one, T82.4, thrombosis due to device, implant, and graft. And it's looking at clots occurring in the catheter. Now, this is exceptionally important because anyone who has been following what happened in the post-pandemic would know that clotting and microclotting is absolutely huge in terms of understanding what is happening. And I've been working in the background at a topic that appears controversial, so I have to be careful when I talk about it. And it's a fact that I've been following for years, unusual clots being noted by embalmers. I mean, I am telling you that in another 50 years, when history comes back, they will be baffled as to why we've had 4 years of embalmers saying, you know, we are seeing something unusual here. We've never really seen this before. And the scientific and medical community going, no, we don't think this is relevant. As I said, from a scientific point of view, anything that changes, I am interested in. And so this is what I do, which is different. I look at everything because I am anticipating there are going to be problems. We said from 2020, the spike protein with the virus was causing severe COVID because it was triggering immune dysregulation where the body started to attack itself. All focus at that time was ACE2, the same entry receptor, but there will be other proteins it triggers. And if it's an autoimmune triggering, any exposure to spike protein is likely to make this worse. I can't put it any simpler than that. And as a result, because I'm looking for that, I therefore can just simply extrapolate. It's not difficult. If you know which proteins are involved, if you know that it will trigger an autoimmune response, you just literally have to think about it. Okay, if there are autoantibodies produced against this, or if the T cells start targeting this, what will the disease be? It's not complicated. It just requires a little bit of thought if you come from a scientific or medical background. And this is literally all I do. And within that framework, it helps me to predict, okay, based on this, this is what it's likely to mean. So when it comes down to looking at exactly what is happening here, I have gone into a little bit more detail with regards to these catheters and dialysis catheters. Before I do, I need to give you a little bit of background. So I've gotten this information from St. George's University Hospital. So just giving you a framework for you to understand. The one I'm specifically looking at is skin tunneled dialysis catheter. And you can see here, so this is from their handout that they give to patients. They tunnel the catheter under the skin, and this is on the right side of the chest. And then they enter into the blood system, artery, and the vein. And you can see here, this catheter is taking blood out and filtering it and then sending back in. And this catheter has to be quite protected, and you don't want it to get blocked because it will then need to be reinserted. And so this is what they call an STDC, a dialysis catheter. And so this is for patients who have kidney failure, and they need to be on a hemodialysis machine. And so you need to have very good access to their blood vessels so that you can exchange large quantities of blood. And for many patients, they will come and have that, say, 3 times a week if they're on dialysis. So it's a very important procedure. And generally, one of them will stay in place for between 1 to 6 months and sometimes longer. And this is while they are arranging for them to have a surgical procedure called an arteriovenous fistula. That's where they have it in the arm. So this is a longer term strategy. This catheter is a more short term strategy whilst they work out what is going on. Now, the procedure itself does have some risks, but that's not what I'm focused on. I'm interested in the bit about what happens afterwards when they go home. So after you've had it put in, and very often it's a day case procedure, and this is important to remember. So day case meaning somebody needs one put in, they get a time for them to come into hospital. So they would come in, say, 8 o'clock in the morning. They then get prepped. They then have the procedure done. They're observed for a little time, and then they go home. That's a day case procedure. And it's different from an elective procedure where you would admit someone, say, the day before or 2 days before the procedure to optimize them for the procedure. That's a very important point, which we're going to come back to. So once it's put in, the principles are simple. They need to, when they go home, they want to keep the dressing over the site clean. They have to take out the stitches. They need to look out for it being red and painful. So all of these things are critical in terms of what you do. Here is where they have problems, an inability to draw blood from the catheter. Now, this is where the problem comes, blocked lumens. Sometimes one of the lumens can become completely blocked by a small blood clot. This is important because then if they can't unblock it by injecting medication to break up the clot, they would then have to take out this catheter and put it back in. So this then has an implication for longer term care in terms of the person then has to have another procedure and so on and so on. Now, that breakdown is very important to understand when I go through this process. And this is here, the T82.4 dialysis catheter complications. When you look at what the data shows, as I said, this is from 2016 to 2025. And what you can see here is a very clear trend of this rise. Primary is in red, secondary is in gray. And in any position, it's a 50% rise. As a primary diagnosis, it's a 60% rise. This is in 2025. If it was a day case admission, as I explained, a 159% rise. This is extremely important, okay? And I'm going to explain why, because this is something that has implications not just for the current situation, but it is very important in terms of what it means about other procedures. Now, I want you to look at something here, because this is the point when I looked at the data that stood out to me. On the left here is the admission method time. On the right is just the sex gender split, male, female. Don't worry too much about this, but look carefully at this one here. 2016, 2025. Red is the emergency thing. So if they've come in as an emergency, you can see that's relatively flat. Blue is elective, where they have been brought in a day or two before because they're anticipated to have problems and they're kept in hospital after. This is flat. What is rising since 2021, 22, 23, 25 is the day case. Now, why would this specifically start to rise with regards to complications for this catheter? Now, there's another thing about this that is very important to understand. It's the age. And as I said, this is some pretty heavyweight data. Just in case there are clinicians watching this, you can look at it. I am happy for other people to put in their own interpretation. I am just analyzing this from my position, from my work, and from what I see, and making extrapolations. The advantage I've got is I am able to look very, very detailed statistics to try and understand what could be happening. And so here we have, again, in terms of the age band distribution here, In red is 2024-25, and in gray is 2016 and 17, just to give us a comparison. And what you can see is if they are less than 40, so these are the ages here, less than 40, 40 to 54, 55 to 64, going up to over 85. In this old age group, the numbers are the least, but there is no great difference between 2025 and 2016. Again, 74 to 70, 75 to 84, if anything, it's a little less than 2016-17. Similarly, for 65 to 74 years old. But when we hit the 55 to 64 years old, the 2025 period is higher, and similarly for less than 40. These are the people who are getting complications. You would normally expect the complications to be in older cohorts. Something is not right. And this complication we're looking at is specifically to do with blocked catheter. So this is really, really important. And as I said, my prediction is that the changes that are happening pathophysiologically are related to the pandemic. And my research points to the COVID storm, spike-triggered autoimmune response mechanism. Essentially, this is something I've been saying for maybe a year and a half, 2 years now. Essentially, what we have is a situation where population has either been infected here or exposed and primed with vaccination, and their immune system has a high propensity to overreact. What then happens is when you have it combined with recurring COVID infection, even mild infections, you get a storm. And that storm tends to impact on the vascular system. And this is what I've been seeing from the data. Across the board, it is a vascular immune storm. Now, as I said, people can choose to ignore that. I am saying that something has changed, and we need to understand what exactly has changed. Based on my research, it points to the fact that the spike protein seems to be damaging the lining of blood vessels. It's kind of like excessive rain causing potholes on the road, and if you leave it, more rain comes and it digs it up further and it damages the cars driving through. That's the kind of picture that I see that is likely to be happening. Now, this leads me perfectly into a very critical area. Now, this is the biggie that you can't really talk about so much, but it's a critical part of what I am interested in terms of understanding the patterns of disease. So let me show you this work that I've been looking at. As I said, for years, I've been looking at strange patterns that the embalmers have been seeing. And I think that this is linked to microclotting. Microclotting, we know, is very strongly correlated with regards to long COVID patterns. And what's very interesting is that some other research that is being done is that Joachim Gerlach has spoken about, is demonstrating that even in people without symptoms, they are seeing microclotting. So this is very important. So at the extreme of it is likely to be what these embalmers are seeing. And this is Richard Hirschman, and he pulled out a 19-inch clot out of somebody. What is unusual about it is the white texture. Very strange. Normally, clots are much more grape jelly-like, and this pattern can only be seen by embalmers because they're the only people who take blood out of bodies after they have died. And so I don't understand why the scientific community is ignoring embalmers simply because they're not pathologists or doctors. It really makes no sense. Pathologists and And doctors don't do what they do. They do a very unusual thing that makes them see patterns with regards to clotting. Now, some people will say, well, it's just embalmers. However, a few years ago, and I probably should have put the link to this, one of the most important discussions I had was with a whistleblower who worked in a catheter lab, and he sent me multiple images that they were pulling out of people. That was what was the game changer in terms of understanding. This was one person. This was from the inferior vena cava of the person. These are the white clots combined with red clots all the way up. This person would have died and have been found on the embalmer's table if they were not able to remove this clot. So the point is that these patterns of clotting are occurring, and there is something very unusual about it. So from a scientific perspective, I have always been fascinated by it. And so I'm going to share with you a little bit more about the science, because the two things are linked. They are going to be seeing increased clotting complications in these vessels because the blood is more likely to clot. And that would be a demonstration of increased microclotting. If the medical community doesn't take this into consideration, what is then going to happen is they will continue to have an escalation in complications over time. But what is the genesis of this? What really may be going on? And so this is my scientific interpretation. And as I said, I've been correlating and collating this data for a while. One of the interesting things, when they looked at one of the clots, because these have been analyzed, and what they found, which was really strange, is you can see here in red high levels of hemoglobin subunit beta and fibrinogen beta chain. And they also have here hemoglobin alpha, but it's like a 3-to-1 ratio. Now, this is very unusual because this is not blood. This is not red blood cells. This is the hemoglobin-free chains. And that really is a critical part of understanding why this occurs. So here is a part of my theory, and I've been theorizing about this for years. One of the things that the whistleblower had said is that when he was anecdotally looking at the people who were having these strange clots, he said the vast majority, he said 99% to be frank, and the few that weren't elephantized, he said that it was because it was unknown. I think in truth, it is a little bit more complex. I think it can happen in both, but I do think it seems to suggest the risk is higher in those cohorts. And the question is why? So here is the essence of the science. One of the interesting things about these, this is an example of an mRNA lipid nanoparticle, and it will have the spike protein in it. And then on the outside, this shell keeps it safe so that it doesn't get destroyed by the body. And this is more like what it would look like. And on the outside, you have all of these phospholipids, these pegylated lipids, all on the outside. And on the inside, not only do you have the RNA strand here, but you also have ionizable lipids in here. And now, Christy Grace had raised one of the most serious issues about 6 months ago. And she was mentioning the point that one of the studies that hadn't been done was the impact of these ionizable lipids after the particle had disintegrated on other proteins. Okay? Now, all I can tell you is that when she did that presentation and when she was doing that research, oh my goodness. I mean, the question was a very good scientific question, but boy, the response she got was a complete shutdown. It was brutal in the way that it was approached because she knew nobody had really looked at this. And actually, the only people that had looked at it indicated that this was very relevant. So now you now have to follow along with the science. So look at this here. As I said, this is now my drawing. These are the ionizable lipids, and they're there to hold and protect the mRNA, the modified RNA, so that when it gets into the cell, it's not damaged or destroyed, and then can be converted into spike protein. Good. So then this is the principle that Christy Grace was talking about. These ionizable lipids then can sometimes become positively charged. If they become positively charged and bind to a protein, not just hemoglobin, but in this case, I've picked hemoglobin, it will alter the shape of the protein. And this is what they call adduction. This altered protein can sometimes be difficult for the body to break down. And the same thing I said could happen with fibrin. Now, this is my thought now as to being one of the points of genesis of these really unusual clots. So again, let's take it another step further. In the bloodstream, you have very specialized immune cells, monocytes. They're called THBS1 monocytes. These are scavenger monocytes, and they scavenge everything. They're like the garbage collectors in the bloodstream, and they are there to protect the lining of the blood vessels. And if there were circulating particles, spike protein, anything, they would then try and pick them up. When it comes to these adducts, where they may have changed the formation of hemoglobin, I realized that yes, as well, this is my image as to what I think happens. These will then be picked up by the macrophage. Now, you just have to imagine, because a macrophage picks up any circulating lipid nanoparticles, anything it will scavenge. Once they get inside, if there is a problem with these ionizable lipids and they bind to proteins like hemoglobin, suddenly now these cells can't break them down, because normally what is supposed to happen is they then take them, put them inside. You could consider this to be some kind of acid that just breaks down everything. That's the lysosome, and it's supposed to break it down. But if it can't, they then get stuck in these immune cells. Because one of the strange things about the white clots is that it's difficult to imagine that they can accumulate so slowly over time and not be seen, because we do angiograms all the time and we are not seeing those big clots. So I know that they are not easily visible. And one of the thoughts I think Dr. Shetty had said is maybe they're lying against the lining of the blood vessels, so very difficult to see on an angiogram. And so my prediction is that you are then having a trigger. This is where the storm comes in, say an infection, spike autoimmunity. You then have a trigger that starts to make traps. And in this case, neutrophil extracellular traps make these nets. They would release them, trap anything floating around, trapping even possibly some of the immune cells. And then you get this whole mush of stuff, antibodies, altered fibrin, altered hemoglobin in these nets. And this is the genesis of the microclot. Now, the microclots are there all the time in a lot of people. And in some cases, this is where they have to do filtration to try and get rid of the microclotting for people who have it very severely. So the transition from microclotting to macroclotting, again, is likely to be another event where you have quite a significant storm where you already have microclotting occurring, and then you have a storm then producing a rapid production of the macroclots. And this is my image where you have these macrophages that are full now of these adducted hemoglobin beta because they are more prone to making adducts. They can't get rid of them. They try and share them around and they're stuck with them. Then there is an inflammatory trigger, and suddenly all of this is released to produce this very high amyloid rich material that is a white clot that cannot be dissolved. Because that's the characteristic that the Pretorius team had found, is that once these clots form, nothing dissolves them. Nothing in the body, nothing outside the body is able to break them down. They form these amyloid type patterns that are extremely unusual. As I say, from a scientific point of view, this is absolutely fascinating stuff. And we're limited by the fact that there is still not enough interest and focus on this kind of research to try and understand what's going on, other than the Pretorius team in South Africa doing a lot of important work on amyloid microclots, because they already confirmed that they are amyloid, very difficult to break down. The body can't get rid of them. The macrophages can't get rid of them. So we know this is happening. The question is that the process that can then accelerate into macroclots? Now, I have to bring you back, because just in case some people have just come, as to very quickly summarize. Essentially, what I've been looking at are some patterns with regards to abnormal changes with dialysis catheters and the procedures that are occurring. And in this case, what we're seeing is that for T82.4 dialysis catheter complications, there is a significant rise since the pandemic of increased clots in these catheters. They're blocking off. This then ties in to the abnormal pattern where if people are having microclotting, my prediction is that they will be more prone to having complications of macroclotting within these catheters. That would be something that would be extremely important to understand, because here is the reality as to what happens. How do you determine a day case from an elective case? They're usually pre-assessed. So they will come into hospital to have an assessment to see whether or not they are a straightforward case. If they are considered to be a straightforward case, they come in as a day case. You bring them in on a day, you put in the catheter, you send them home, because they shouldn't be complicated. If you anticipate them to be complicated, you then bring them into hospital a day or two before, so that you can make sure that they are handled properly. What the data has very clearly demonstrated is that the day cases are having the most clots. I suspect it means that they are not picking up in pre-assessment that these people are more prone to clotting, because they probably already have significant microclotting. This is where you can get the connection between what the embalmers are seeing, what the Pretorius team is seeing, and the complications that are happening across the board. This is the kind of work that needs to be done. What is scaring everybody off? Elephants everywhere. Everybody is afraid of elephants. And if you don't understand what I mean, I've got an image here that shows my elephant sitting down. I'll show it to you here. This is my picture of the elephant in the room. Nobody knows. They are just baffled. There's a huge elephant sitting on the couch. Nobody knows why it's there. Nobody's interested. They are just baffled. We need to get beyond this kind of science and medicine. And this is what I am here to do. I am challenging the science because I've got the data. You can't tell me anymore that this is anecdotal. It is not. It is a very clear trajectory that something has changed. We are seeing it in multiple organ systems, the heart, the brain, the kidneys, the liver. I'm going to do lungs and the gastrointestinal system soon. It is going to be across the board. It cannot be denied that this is happening. The problem now is, will the work be done? Finally, I will just check and see if there are any relevant questions that I would probably take on. Just looking for something that's not too controversial. So if you have a non-controversial question about this, please just put it in. Question should be, this is a good one, why are so many on dialysis? I did a presentation on this, the Awakened 1447, and it's because more people are having kidney failure. I think that there are three primary drivers, which I've just recently done. And as I said, it's a similar pattern: vascular damage, increased hypertensive damage, increased damage to the tubules in the kidney. This is what I think is going to be part of the main reason. And somebody points out here, nattokinase is good for natural clots. This looks like President Putin, and great for you to join. Yes, in theory, yes, nattokinase does work, but for these kind of clots, I think that this is beyond it. And here's the problem. If you only focus on the clots and don't focus on why the clots are there, I still think you're missing part of the problem. And so I think we need to study it in a different way and try and understand some of these mechanisms. Peter, why won't UK universities go near the clot? I think it's down to funding. You have to understand how it works, is that because if anybody starts to investigate this kind of thing that could be considered to be controversial, they are then going to have to go through the grant process down the line. You want to get funding. And so why are you going to do research that could either make it more difficult for you to get funding or put you on a blacklist? And so quite naturally, the scientific community is primarily researching what they can get funding for. And at the moment, I don't think anybody's going to pay for funding looking at these kinds of unusual clots. The small amyloid clots, yes, certainly Pretorius and so on, is therefore getting and doing that. Someone pointed out, as someone suffering long COVID, can these clots reach the lungs? I mean, the microclotting will reach the lungs, but they probably pass through the lungs in quite a lot of cases, and they can do problems in different organs. The macroclots, the big ones, I truthfully don't want people to worry about it because there's nothing you can do differently. If something like that happens, you need to be in hospital and have a pretty significant intervention in order to survive that. These are life and death scenarios. So it's not going to be something that happens to someone as a minor thing. That's a pretty major thing that would be happening. This question here, I think I should deal with as a whole separate one. Can you explain how the new cancer vaccines are different from mRNA so-called vaccines? Yeah, I think that's a big one that I probably should look at completely separately to try and answer that as well. So thank you all very much for sitting with me as I do my analysis. As I said, at the end of the day, I'm making you aware of some of these patterns that are real. And so it's not in your head. It's just not openly acknowledged yet. It's going to take years. Someone asked me how long. I think it could take a decade. And so in the interim, I'll just keep on talking. At some point, we have to force the scientific community to do the research, even if it's inconvenient, even if it may have litigation associated, and try and get that done. As I had mentioned before, the reason this is unique is that I have three things that I think are quite relevant. And this is the combination that I'm talking about here, is that when you look, I've been doing the COVID research for 6 years. over 6 years now. I am looking at this detailed epidemiology of hospital episodes, and I know how hospital works. So this analysis I know is quite significant as a marker. It can't tell us exactly what is the cause, but it can't be ignored for too long. So thank you all very much. Have a great evening. I look forward to bringing you more information in the near future.